Now from lateral geniculate body, as I said, there comes the optic radiations. But the optic radiations are arranged in two bundles. One bundle is called superior optic radiations, which passes through the parietal lobe, and they are also known as Baum's loop, and inferior optic radiations which passes to the temporal lobe, which are also known as Mayer's loop. Right, so from lateral geniculate body, optic radiations arises. There are two bundles. One bundle passes through the inferior temporal lobe, which is known as the Mayer loop. Next bundle, that is superior optic radiations, passes to the parietal lobe, and it is known as the superior optic radiations, and both of them come together at the occipital lobe. Both of them, they join together at the occipital lobe. Now why this is important is because the lesions at the parietal lobe or Baum's lobe or the superior optic radiations produces the different kind of visual field defect, and the lesion at the Mayer's loop or inferior optic radiations produces a different lesion. Why? Let us see first here. So what we can see here is that these are our eyes, and there is a bee which is looking, it is in the downward natural field. Okay, so it is just below the level of the eye. So when we have to look at this bee, this is the superior retina and this is the inferior retina, isn't it? This is the inferior retina and this upper part is the superior retina in a normal position. So when we are putting a downward gaze to look towards the bee, we will look it like this, right? So the light from this bee is passing in the superior part of the retina, which I have already explained. Okay, so in here also you will look like this. So the light rays from this bee, it is passing on the superior retina. Here also superior retina, in this also superior retina. So when we have to look anything that is below in the inferior visual field, the light rays are passing in the superior part of the retina. Suppose this bee, it is at the superior part, that is above the eye, above the level of the eye. Then to look at this, we will move our eyeballs like this. Okay, so to look at this, we will move our eyeballs like this. So when you are moving our eyeballs, the light from the bee or the impulses are going towards the inferior part of the retina, isn't it? So whenever in the superior visual field, okay, in the superior visual field, from the superior visual field, the lights are going for to the inferior part of the retina. So because of this reason, okay, because of this reason, so whenever there will be lesion at this loop, which is the superior retinal fibers, okay, which passes to the parietal fold, this is superior retinal fibers, this Bowman's loop which passes to the superior parietal fold, that means in the superior part of the retina. So which field of defect we will see? We will see the field of defect in the inferior part of the visual field. Okay, there will be the loss of the inferior visual field. It can be inferior nasal and inferior tabular. So if in the left side there is a lesion, so left sided inferior nasal and right sided inferior temporal visual fields are affected. So I will show again in the picture. So what I wanted to show is, this is the part. Okay, so here is the lesion. This part is called the Mayer's loop. Okay, this part is called the Mayer's loop. So it is going towards the Mayer's loop is going towards the temporal part of the brain, and it is taking the inferior nasal fibers. Okay, inferior retinal fibers. So inferior retinal fibers, and it is called Mayer's loop, and it is going towards the temporal lobe. So here also similar way it goes towards the temporal lobe. So in this part, what kind of fibers you can see are, so temporal fibers of the same eye and the nasal fibers of the opposite eye. So since there is temporal fibers of the same eye, so the visual field in the same eye will be at the nasal side. Since there is nasal fibers of the opposite eye, so the visual field lost in the other eye will be in the temporal side, but it will be only limited to the upper half of the eye, that is upper nasal and upper temporal only, because these are the inferior fibers, and defect in the inferior retinal fibers means inferior retinal fibers take the vision from the superior visual field. Okay, superior visual field. So the superior visual field will be affected, not the inferior one. let me again explain it once again. So as I showed here, the same situation. Suppose the Mears loop, they are the inferior retinal fibers. Okay, they are in the inferior retina. So they what they do is they take the visual impulses from the superior visual field. Okay, from the superior visual field, the light goes to the inferior retinal fibers, that is the Mears loop of the optic radiations. So if they are damaged, then what will happen is that the superior visual field will be affected of the eye, inferior visual field will be intact. Okay, there is no lesion here, there is a lesion in only the inferior part of the retinal fibers. So the inferior part of the retinal fibers, they play the role to take the visual impulses from the superior nasal field, superior nasal and temporal fields, okay, both. So that is the reason why we get the diagram like this. Whereas when the Baum's loop is damaged, which is this one, Baum's loop, it gets the superior orbital retinal fibers, and it has the superior optic radiational fibers, and it passes through the parietal lobe. So when the superior optic radiations are affected, which means the superior part of the retina, and the superior part of retina is usually used to look at the inferior nasal field. Okay, they are used for inferior nasal visual fields. So that means that if these are damaged, then inferior nasal visual fields will be affected, isn't it? So if Baum's loop are affected, then inferior nasal and inferior temporal visual fields are affected. So in left-sided inferior nasal and right-sided inferior temporal visual fields are affected, which is also known as pie on the floor. So I want to show you. So like this. So pie on the floor, pie on the sky. Pie means this much only. So you know what is pie. So pie on the sky, and this is called, that's why pie on the floor. It looks like a little pie of cake, and it looks like in the floor. So pie of the floor, and then pie of the sky. That's it. So this is about the defect in the slope and Mears loop. So once again, let me revise it. So whenever there is defect at the Mears loop, which is the inferior nasal optic radiational fibers, which are the superior or inferior optic radiational fibers, so they arise from the inferior part of the retina, and inferior part of the retina means that they will take the visual field of the from the superior nasal or temporal visual field. They will take the impulses from the superior visual field. So superior visual field defect will be seen. If the superior retinal fibers are damaged, then inferior visual field will be affected. And here, since only the one part, that is Mears loop or Baum's loop, one part is affected, so there will be just a pie will be affected. Half of the upper part of the nasal or upper part of the temporal field will be affected, and we get the result like this, which we can say like right-sided contralateral superior homonymous quadranopia, or right-sided contralateral inferior homonymous quadranopia. Superior homonymous quadranopia, inferior homonymous quadranopia. That's what you can say. And when both the loops are getting affected, then we say complete homonymous anopia. If Meyer loops, then superior homonymous quadranopia. Quadrant means one quadrant, and inferior homonymous anopia means one quadrant. So we can divide our eye as upper quadrant, lower quadrant, superior retina, inferior retina, superior homonymous, hemi-homonymous. I have already explained, same side. If there is in the same side, homonymous. Hemianopia, quadranopia means one quadrant only, and superior means superior part. If inferior means the inferior part of the retina. It's very easy to understand. So this is what all about the regions of the visual pathway. So that's about it. So the usual causes for the lesions of the optic radiations are vascular occlusions, tumors, trauma, and or temporal lobotomy for seizures. These are the causes for the lesions at the optic radiations. So this is the mnemonic, and you can remember it as TIPS, where T stands for temporal lobe disease, I stands for inferior optic radiation. So temporal lobe means inferior optic radiations, which gives the superior visual field loss, that is pi in the sky. P stands for parietal lobe disease, which means superior optic radiations, and inferior visual field loss, that is pi on the floor. I have already explained it. Now let's move towards the brain and towards the visual cortex. So this is our brain. You can see here, it's a beautiful brain. Okay, this is the frontal part of the brain. Okay, this is the temporal part, this upper is the parietal part, and this back one, it is the occipital part of the brain. And as you all might know already, that the visual cortex lies at the tip of the occipital area, so it lies somewhere here. Okay, somewhere here it lies the visual cortex area of the brain. So now what happens is that, as I said, the last point of the visual pathway is in the occipital lobe, that is occipital lobe of the brain. So when it reaches the occipital lobe of the brain, here in the occipital lobe, it is supplied by two kinds of the arteries. One is the posterior cerebral artery and another one is a middle cerebral artery. The, the posterior cerebral artery supplies almost all the part of the occipital visual cortex. Okay, it supplies almost all part of the visual cortex. Let me show you like this. This is just a representation for an example point of view. So maybe let's look at this. Suppose middle main posterior cerebral artery is supplying the all part of the visual cortex, except a point which is called the macular area. Okay, so this is called the macular area. So actually this is not a macular area, the tip of the cortex is the macular area. The tip of the cortex over here, there is the macular area, but I want to make it just clear for an example purpose. So just the tip of the cortex, it is supplied by the which is called the macular area, it is supplied by the middle cerebral artery, whereas most of the part of the visual cortex is supplied by the posterior cerebral artery. So most of the occipital cortex is supplied by the posterior cerebral artery. In up to 75% cases, middle cerebral artery supplies the posterior tip of the visual cortex, which has representation from the central visual field called macula. So why it is called macular area? Because it gets some of the very precise visual impulses for the macula in this part. So that is why that's the reason why it is known as the macular area. Okay, it gives the representation from the central visual field called the macula, so that's why it is called as macular area. So in the lesion of the visual cortex, if the posterior cerebral artery is injured, okay, there is any cause the posterior cerebral artery is injured, then what will happen is that the middle cerebral artery is supplying the macular area, therefore there will be no any vision loss in the middle macular area, and there will be vision loss only in the areas which is supplied by the posterior cerebral artery. And as you already know that from the in each half, one temporal fiber of the same eye and one nasal fibers of the opposite eye, it comes here. Okay, so the vision loss will be, since the temporal side fibers of the same eye, okay, the special opposite, it's a left eye, then temporal fibers of the left eye and the nasal fibers of the opposite eye is there. So that means if there is a lesion, that means nasal temporal fibers of the same eye will be affected, which means the nasal visual field defect will be there. In the opposite eye, since the nasal fibers are there, that means that they will be get affected, that means the temporal visual field will be affected, right? But there will be macular sparing, so you get this kind of picture, which is homonymous hemianopia, which is similar to our this diagram. Okay, so here and here, so here in this diagram we can see that this and this diagram we could see, right, in 5 6 7 5 6 and diagram number 8, it is similar to that. There will be homonymous hemianopia, okay, because the one fiber is from the temporal side and one fiber is from the nasal side. Temporal side is from ipsilateral one and nasal fiber is from the contralateral one. So since temporal fiber is there, it is getting destroyed, so nasal visual field of that same eye will be affected, and since the nasal fibers of the opposite eye is there, so the temporal visual field of the opposite eye will be affected, leaving the macula. But what if what if there is the injury in the middle cerebral artery. So when there is injury at the middle cerebral artery, often due to trauma, what happens is that only the central part will get affected. Only the central part will get affected. That means the macular region will only get affected, and the vision loss will be only in the macular area, giving this kind of appearance. Whereas when there will be a lesion at the parieto-occipital fissure, that is somewhere here, okay, in the parieto-occipital fissure there will be lesion, then we will get something like this kind of the visual field defect, which is known as the monoocular temporal crescent defect of the right contralateral right visual field. So monoocular temporal crescent defect of the right contralateral visual field. This is not very important, but these two are important. So in the posterior tip of the visual cortex, if there is injury in the macular area, then only the macular area will be getting injured, so right homonymous macular defect. And if there is the injury to the other part of the visual cortex except the macula, which is only in the if only posterior cerebral artery is injured, then there will be homonymous henopia with the macular sparing. These two you should know. This is not so important. So this is all about the visual field defects that we can see in the visual pathway. This is all. There is nothing much. If you have any confusion, then you can please comment down in the comment section below. That's it for today. I will be again talking about the other part of the neuro ophthalmology in the upcoming series. I would like to request to all my friends once again, please do not leave any series of this video, because I might be saying one information in one part and another information in one part, so you might not get full information. So if you go with all the series from series 1 to part 1 to other parts 2, 3 and 4 in a serial way, then you can understand everything that I will be explaining here. So I hope that you like this video, and please do like, share and subscribe to my channel. Thank you so much.